I'm Dan from Correct Osteo Clinic, and today I'm going to talk to you a little bit about the knee. So we see a lot of patients with knee pain, and you can sort of see why. I mean, the knee is the biggest joint in the body. I mean, look how big it is, you know, compared to other joints in the body, like the little ones in the spine and so on that we was talking about in another video. Even the actual hip joint itself, about here, I mean, the knee is a big old structure. You know, it's got a weight bear quite a lot during the day, moves constantly when you're walking as well, into sort of flexion extension, and you've got other accessory movements as well. Like you do get degrees of sort of side bending, you know, left and right, so you get more of a valgus strain where the knee sort of concaves inwards slightly, and you can get a varus strain, so when it comes sort of a bowed leg slightly. So you'll normally see that in things like osteomalacia, people with vitamin D deficiency, that sort of thing. You can get a bowing of the legs, and obviously that valgus strain as well, where it goes inwards, that I talked about just a minute ago. So it concaves sort of inwards, so it's like two sort of V's pointing towards each other in a sense. Okay, so the knee, you know, so it has to go through quite a lot of strain during every day. It has got arterial supply from like the geniculate artery. It's got multiple nerve innervations from like femoral nerve and tibial nerve. It has a lot of musculature that surrounds the knee to try and keep it stable. So you've got your quadriceps, which will come down the front as well, so rectus femoris, vastus lateralis, vastus medialis, vastus intermedius, so that sits underneath the rectus femoris. So rectus femoris is also a hip flexor muscle as well. These quads will all attach onto this patella tendon, as you can see here, this big thick tendon that will go over the patella, so the people call it the kneecap. Okay, so you can sort of see it there, and then it will go down and attach onto what's called your tibial tuberosity. So this is the shin bone here, okay, the tibia, and it attaches onto that little sort of ridge there that you might be able to see, called your tibial tuberosity. Okay, you can get problems in that sort of, teenagers can get problems there when they're going through their growth period. If they're doing like a lot of sports as well, you get a growth plate in this area here of your tibia, and the strain from the quads can actually pull on that growth plate, and it's called Osgood-Schlatter's. You can also get another problem further down the leg called severs, where you get a growth plate within the calcaneus, and that can get quite inflamed as well. Direct sort of pain over the sort of heel, that can be a problem. So you've got also some ligaments here. Oh, let's go back to musculature actually, because we talked about the quadriceps. You've got the hamstring musculature, so they're at the back of the thigh. Okay, they sort of come down and they attach onto different points of the knee. So some of them attach onto this fibula bone here, this fibula head. Oh, there's my pen. This fibula head here. Okay, so this sort of area. You can see here the lateral collateral ligament, which attaches over there as well. Okay, that's again for stability of the knee. And on here you can see the medial collateral ligament, but I'll talk about the ligaments a little bit more in a second. So the hamstrings, they come down the back of the thigh here, and like I said, some of them attach onto here, and then others will attach onto, they'll wrap around here, and they can attach onto this sort of area here of the tibia again, called your pes aceri. Okay, so there's a tendon here called your pes aceri tendon. There's also a bursa. Bursas are fluid-filled sacs that allow friction and allow sort of like compression. Well, they reduce friction and allow sort of like compression of the musculature against other, say, muscles and even bony landmarks as well. So they allow like a sort of gliding, they're like a buffer as of such. There's different studies to suggest that there's actual different amount of bursa around the knee. Some studies say 11, some go up to 15. So you can actually grow bursas as well. So not a lot of people sort of know that, but you can actually grow bursas under trauma as well. So if there's a lot of, say, like friction or trauma going on around specific areas, your body can actually even grow these fluid-filled sacs to allow a little bit more sort of compression and friction in those areas. You've got your adductors as well that will come down in sort of medial. When I say medial, I mean it's more towards the center of the body. So the inner thigh, they'll come down this sort of area as well, attach onto sort of like femur areas and all that. Medial sort of condyles. So you've got these big condyles. Let's talk about these for a second anyway. So these big condyles here, these big ridges that come out of the femur. So the femur comes down here, and you've got these big condyles here, and you've got another one on here, as you can see. Okay, so these this medial condyle, this inner part of the knee, is a lot bigger than the lateral side, so over here. Okay, so if you say my arm was the femur, if I stood up and I showed you, this condyle here is deeper than the one on the outside. So if I made a fist with my hand here and I pointed it downwards, as you can see, my fingers, when I'm making it with a fist, it points a little bit further down on this side than it does on that side. So it's a little bit shallower towards the outside of the knee, but on the inside of the knee it's a little bit deeper, okay, because that condyle, this one here, is deeper, so it presses a little bit more in. Okay, and that's because the medial portion of the knee is for stability. So, and the lateral portion, so the outside portion of the knee, is for mobility. So we'll start talking about the meniscus now then, about mobility and stability. So meniscus is like a cartilage within the knee. Okay, so you have got what's called articular cartilage, which surrounds the bone, okay, of the actual knee joint, where the femur, this thigh bone, meets the tibia, the shin bone. On either ends of those, you've got an articular cartilage. It's very slippery. I think it's even slipperier than ice, and it can be compressed up to 5 to 20% of its thickness as well. So it's very sort of, it allows for some shock absorbing, and it allows for movement. So it's easy for the knee to go into those movements, like the flexion and extension movements, and again that side bending, and even a bit of rotation. Okay, but when we talk about rotation, like I was saying earlier about the stability of the knee, the medial portion, so the inside portion of the knee, is for stability. The outside portion is a bit more for mobility. So the meniscus on this side, these are like I said earlier, they're like cartilage within the knee. They're sort of two C shapes, okay, like that. So if I popped them both out, they're like that, okay. So the two C's sort of pointing towards each other, okay. The medial one, again, is for mobility. The lateral one allows a little bit more, this one is for stability. The lateral one is a little bit more for mobility. So you'd normally get a medial meniscus tear. Okay, so because of this one is actually for stability, if too much rotation goes through it, so say if someone jars the knee, or falls in an awkward way, twists the knee slightly, because of the outside one, again, like I said, is for mobility, the inside one doesn't move too well. So if that does move, you're more likely to get damage here. Okay, and the first 25% of the meniscus, so the very outside portion of the meniscus towards the outside, so towards the outside of the actual joint, holds the best blood supply. When it goes further back, it starts reducing in blood supply. So if you have got, like, say, or if you do unfortunately get like a tear towards the sort of like back part, or the very sort of inside of the meniscus, it's less likely to recover from that, and you can get like popping and clicking within the knee, even locking as well, pain with like sort of rotation, maybe even going up and down the stairs as well, sort of putting load through it. Unfortunately, when you get some tears like that within the meniscus, and even in the actual cartilage as well, you get that sort of wearing, that disrepair of those areas. It can predispose you later on in life to, like I said, that disrepair, so things like osteoarthritis of the joint. So going back to sort of that stability of the knee, we'll talk a bit more about the ligaments now. So you've got your lateral collateral ligament that I explained earlier, and your medial collateral ligament, also known as your MCL and your LCL. Okay, you've also got another couple here as well called your posterior cruciate ligament. So here, all right, and right deep within the joint, you won't be able to really see it here, I wouldn't have thought. But right in there, you've got what's called your ACL as well, your anterior cruciate ligament. Okay, so these are all for obviously stability of the knee joint itself. You can stress them in obviously different ways. So if you, like I said earlier about that sort of valgus strain, so when the knee sort of side bending sort of inwards slightly, you can get a stretching. You might be able to see on that video, you can get a stretching of that MCL. A lot of people will get weakness from this due to things like doing long time like breaststroke as well, because of the amount of stretching that will go through the MCL. Okay, when you get that varus posture, so like I said about the bowing of the knees, the bowing of the legs, like you see in things like osteomalacia, or other known as rickets, you'll get a stressing of the lateral collateral ligament. Okay, so that outside portion, you might be able to me seeing stretching it there. Okay, right, so the cruciate ligaments will restrict amount of drawing of the knee. Now I don't mean with a pen and pencil and a bit of paper, I mean like when it draws forward and it draws backwards. So if it goes, say if you see my fist here, if it goes anteriorly, so if it draws anteriorly, so forward, or if it draws posteriorly and goes backwards. Okay, so the ACL, so the anterior cruciate ligament, if this was the front of the knee where my watch face is, what you're going to do is the ACL, the anterior cruciate ligament, will stop it from drawing forward, and the PCL will stop it from drawing backwards. Okay, the ACL is more commonly sort of ruptured or damaged with things like rotation, like pivot movements. So if you pivot on the knee, say if the foot is stable and a degree of rotational force will go through the knee, that's when ACL can be most likely damaged. Also, like a bit more of like things like impact, say like bad tackles in football, that sort of thing can cause that to be to even ruptured or damaged. The PCL is more common with trauma, massive amounts of trauma of the knee, say like even things in like a car crash, that sort of side of things, where it really pushes and shunts the knee backwards, and then that's when that posterior cruciate ligament will become more likely damaged. Okay, unfortunately with some of the ligaments of the knee, when they're damaged, say like for instance your MCL, this medial collateral ligament here on the inside, that has fibres that even attach onto the meniscus, that blue like structure you can see in here. So when that sometimes gets torn, it can even tear off fibres from the meniscus as well, so you can get what's called like a bit of a double crush. Double crush sounds really horrible, but it just means two problems probably going on at the same time, so that are probably a little bit more unrelated in that sense. So you can get a bit of tearing between the meniscus and the MCL. They're sort of like best of friends in that sense, so if I go you go, that side of things. So you've also got your patella here as well. So your patella, which is your kneecap, obviously you can get issues underneath the patella, so you can get things like chondromalacial patella, where the cartilage starts to wear down underneath the patella. This can be due to things like maltracking of the patella, so when it's not sort of gliding as it should and moving as it should, especially when sort of knee is like going into that flexion and extension position. Say if you've got weakness in the quads, it's more likely in females due to instability issues. So if they have most likely weakness of the actual quadriceps itself, it can track the patella into different areas that it's not really supposed to go. And obviously, if it's tracking into a specific area, instead of gliding sort of superiorly, inferiorly, sort of going up and down when you're flexing and extending the knee, there's different condyles, you see, so different sort of like facets in a sense, so different grooves on the back of the patella. Okay, so you've got these different sort of grooves on the back of the patella. So what it can do is it can start to wear down the grooves on the back of the patella on specific ones. Okay, so again, like I said, you've got cartilage that will actually be on the surfaces of these bones to allow that sort of movement. But again, when that wears down, say through patella maltracking, it can damage that cartilage. You can even get little bits, little fragments, like bits of sort of sand and grit underneath the patella that can grind and be quite painful and quite inflammatory as well. So I mentioned a little bit about bursas earlier. You can get something called bursitis. So if there is, say, too much friction or pressure on a bursa around the knee, so they're located at all different places around the knee, you can get what's called bursitis. So that friction and inflammation of bursas can cause that, and they can cause a bit of swelling, pain, heat, sort of redness. Quite a big sort of, you can even be characterised by quite a big lump over the actual area of the bursa as well. What else? So we've actually got the knee joint itself. So I've talked a little bit about osteoarthritis, so that disrepair of the actual joint itself. We talked about musculature, we talked about patella, we talked about ligaments, we talked about the meniscus as well, bursitis. And you can also get like rheumatic issues, like rheumatoid arthritis, or even things like another inflammatory problem like gout as well. Gout in the knee. It's a most common probably area is like the big toe, but you can also get it in the knee as well. So uric acid crystals can build up into the arteries of the joints and can become quite inflamed and blocked, and they can get really aggressive, so it looks really sort of red, swollen, horrible, really like painful to put weight through it as well. And you can also get like gout of the ear even as well. So not a lot of people, everyone thinks that gout is more common in it is more common in the toes, but everyone just thinks it's due like in the toe and nowhere really else. However, you can get it through like multiple joints of the body. Like I said, even in the ear as well, you can get gout. So yeah, you've talked about like rheumatoid arthritis, osteoarthritis, like gout. You can get things like pseudo gout, which is slightly different to the uric acid crystals. So you get like calcium crystals that will start to form instead of uric acid crystals. And yeah, so you can get instability of the actual joint as well. So don't forget that it's not just the joint where the femur meets the tibia, or even the patella meets the femur. You've also got this fibula joint as well that meets the tibia. So there can also be problems in this joint as well. So if there is like instability issues and whatnot, you can get issues here as well. You've got what's called a peroneal nerve, which comes down the leg and it can wrap around this fibula as well. So when you do say get like a problem or issues with the fibula, if it is unstable, you can also get a pull-in or damage to that nerve, and then that can affect that peroneal nerve pathway. So that is another issue as well. Don't get me wrong, there's loads of other issues that we can talk about through the knee. It's actually one of my favourite joints to work on as well, the knee. But we'll be here all day if I was to talk about every single problem of the knee. So I hope you have a good weekend. Thank you very much for listening if you did. Sorry if I was boring. Tried to make it as interesting as possible and as easy to understand as possible. I hope you have a nice day. Thanks.